These are three of my favorite people talking about global health politics and global health governance in general. So I'm really looking forward to getting your insights and having a conversation with our attendees. So before we jump into some of the details about the responses that we've seen to COVID-19, I wonder if you all could just kind of make sure that we've got that good basis of understanding, like what is COVID? What is this epidemic? Like, where is it coming from? What's kind of the basic trajectory of what we have seen with COVID-19?
So I'm willing to jump in to get us started, Jeremy. So COVID-19 is the term we use to describe the disease caused by a virus, SARS-CoV-2. SARS-CoV-2 was identified in January this year after there were cases in late December of a pneumonia of unknown origin in Wuhan in China. And I'm sure we'll talk about the reporting and the timelines over that sort of December-January period and how that relates under international law and obligations and the role of the WHO. But what we've seen over the last now 10 months is essentially the emergence of a novel disease, its development of it as an epidemic, its transmission to countries in the region, and then now this shift into this pandemic where we have multiple epidemics around the world. And despite these sort of international travel and trade bans, which we can discuss the evidence and the norms and the law of that as well, is essentially seeded across the world with local transmission occurring in all continents except for Antarctica. So this explosive spread of the pandemic is obviously much more than what we saw with, say, the first SARS in 2002, 2003, where it sort of burnt hot and fast. And what we can sort of expect from a trajectory is we now have, after some lulls and decreased epidemic curves in some of these epidemics around the world, we're now seeing across Europe, the United States, where we kind of never went down, but across Europe and other countries, it's starting to surge again. And then other success stories around the world where cases were kept very low, or the epidemics were managed quite rapidly, quite quickly. And the core of that is the effectiveness of public health response and governance. And what we're going to be looking forward for the months ahead and you know, the years ahead is really going to be a matter of how we implement those public health strategies, governance, and you know, potential advances in treatments, rapid diagnostic testing, and of course vaccines.
Excellent, thank you. That gives us a good foundation here, and you know, especially this idea that we've seen this really, you know, explosive growth over what, 10 months now, and you know, has really posed a pretty significant challenge to the international community and to individual national governments. And you know, as we're thinking about these sorts of responses, what is there anything, or I guess, what's the gold standard of responding to COVID-19? Are there any sorts of qualities or characteristics, not necessarily identifying specific countries, but what sorts of things, if we're going to say this country had a good response or this organization had a good response, what sorts of things would we be looking for? Matt, do you want to jump in?
Sure. Look, what we'd be looking for is a kind of 5 or 6 different kind of levels that we might think through. So one is just, what does the public health response look like, right? And so, you know, we do know at this point how the virus spreads, even though there are massive debates about exactly, you know, how much of it is airborne, how much of it is via things that we touch, et cetera. The basic modes of transmission we're pretty clear on at this point. And that means that you've got a couple of different options. One is you need to be doing testing at a high scale and at a very strategic scale. You need to be doing tracing of those that are positive, right? And tracking them and being able to isolate people who have the virus. It means public health messaging to tell people what the virus is, what kinds of things they can do to protect themselves. It means ensuring that there's enough medical care available, right? And so we just know that there's a wide variety of interventions, including many that are quite basic, that can have a huge impact on people's survival rates. And so making sure that that's available and that that's linked up. And then there's a whole set of questions around how do you give people the tools to be able to stop transmission, including things that they don't actually want to necessarily do, like wear a mask, right? And so things like ensuring that there are mask mandates and ensuring that people have both the information they need to understand why they should wear a mask and proper ways in which that is required in certain settings has been central to good responses. And the other piece that's been really critical has been some limitations on the openness of society, right? It has just been true that we are currently faced with a virus for which there is still no cure and still no vaccine. And if you have a virus with no cure and no vaccine that is airborne or various other ways that it is transmitted, what you need to figure out how to reduce social interaction, because that's what's happening. And so, good governments have figured out how to support people to reduce interaction in ways that are clear and useful, often without necessarily resulting in massive police response, right? So the other thing I'll just say is that also good government, good responses are thoughtful about what the human rights of people are. And so, the kind of fight right now in the United States, as we're all kind of increasingly clear about, is, lockdowns or no lockdowns. Is that a thing? And I think that's actually a really unhelpful debate, which we can get into as we go. But the core piece is, look, we need to restrict people's movement. We need to restrict the social openness. But with that comes huge inequalities and huge challenges, right? Who can go to school? Who can't go to school? Who can go out for what? What does that look like? What kind of equity pieces does that have? So the second part is kind of, around the world, we've seen bad responses, militarized, and really moving police out to kind of, really enforce things rather than supporting people, asking questions about why people aren't able to necessarily follow social distancing practices. And the other key piece is to recognize that if you're going to shut down or even just limit economic activity, that is going to have a massive impact on people's lives. And so good responses say we can actually figure out how government can solve for the problems that citizens are facing, and recognize that. So with social supports, with unemployment insurance in the United States, with other things that make it possible, because the bottom line is nobody wants to experience transmission, nobody wants to be transmitting, but people have to make decisions every day. And so good government responses balance the support to people alongside the kind of good public health provisions.
And I think the other thing that stands out with the variety of government responses we've seen, there seems to be a set of countries that acted quickly. They moved proactively, and they sort of erred on the side of being more careful, exercising the precautionary principle, acting even before they had cases necessarily. And so you had this set of countries that moved fast enough that they could try to bring things under control and then kind of get back to something like normal. And then you had another set of countries that decided that they were going to pretend like everything was normal until things were out of control.
I think that's a really great point, is that the importance of early, rapid mobilization of your public health response, right? And so I think there were countries, in the US is a great example, where the earliest kind of response we saw was the use of a travel ban on China, right? And not only does that ignore the fact that the New York City epidemic was started from cases coming from Europe, there are broader implications for international law and international governance through the use of travel bans and what that's going to mean for our pandemic preparedness going forward. But the point about this early intervention, I think, is going to be really critical when we do these after action reviews and when we start to go forward, because we can't really reset the clock. What we will have is countries around the world perhaps getting quite low. Australia is going to be one example. New Zealand's managed to get elimination domestically, but countries getting quite low. So whether they get to the point where they can then not necessarily restart the clock, but get their public health systems in a place to be able to respond as we start to see other local transmission. And I think the point that Matt made points that Matt made were really spot on. I think there's going to be a lot of comparisons between countries between nature of lockdowns, between the nature of measures that are imposed. And there has to be nuance in these comparisons, because a lockdown in Wuhan is not the same as Lombardy or New York City or Melbourne. And yet they're often compared as very similar. And, you know, this goes also to say the police responses. We look in, say, in Victoria, where there is currently stayed quite significant restrictions in place. And we have the mobilisation of police quite actively, heavily fining people. And that burden is disproportionately borne by migrant populations, already vulnerable populations, low socioeconomic populations. And so, you know, even these apparent success stories that we're seeing, we really need to sort of peel back the layers and see who's actually being most affected by government responses beyond simply COVID-19 case counts and deaths.
That's a great framing for thinking about these sorts of national responses. But I want to think about this issue of sort of the global response. You know, we've heard a lot of criticism and praise for the World Health Organization. Where does an organization like that fit into all this? You know, we've been talking about what governments need to do in terms of policing, in terms of being able to provide some sort of social insurance or some sort of replacement for an income or these sorts of things. So what role does the World Health Organization play, just, you know, broadly in terms of responding to something like this, but more specifically with COVID-19 itself? How does it fit into things?
I guess I can start that one. So WHO has 3 roles, and then in this case, it kind of has a 4th role. First and foremost, it's a political organization. It's a forum, it's a body of member states. And it plays that role here. It's where governments negotiate, it's where they hash out laws, it's where they blame each other for doing things not right, et cetera, et cetera. It's also the chief scientific and normative agency. So its job is to process data, to figure out what's happening, to bring scientists from all over the world together, to develop guidelines, to issue recommendations that can help governments decide how to respond, and doing that. And then the third thing is that it's a global coordinating mechanism, or the orchestrator, right? And its job in this case is to kind of coordinate all the global response from different governments, from different UN agencies, from other actors around the world, and try to bring some kind of coherence, some kind of agenda and framework to this. And in that sense, it's really limited by how willing all of these other players are to be coordinated and to collaborate with each other. I really like the term orchestration here, because it's telling, right? Like if you have a conductor and you have a bunch of musicians who aren't willing to play together and follow the conductor, then all you have is like chaos and horrible cacophony. And that's exactly what you get in global health sometimes when you have sort of all these other actors who aren't really willing to follow WHO's lead. And then the 4th thing that WHO does in health emergencies is that it plays somewhat of a humanitarian assistance role. It provides assistance directly to lower income countries and test kits and PPE and stuff like that. And so it's been doing that as well.
That's a really helpful way of framing it. And I like that orchestration sort of way of thinking about it. That's a really helpful tool. To pick up on something that Alex, you brought up, what sort of international legal obligations do countries have when we're talking about infectious disease outbreaks? So if they have cases of COVID, are they obligated to report those to anyone? What are the rules that exist around putting some sort of travel ban or putting some sorts of restrictions on movement across international borders? Where does international law fit into this sort of thing?
Yeah, so our primary instrument is one of the instruments that Mara mentioned earlier, which is the International Health Regulations. And it is a legally binding treaty. It's perhaps the only opt-out treaty that exists in international law. And it was revised following the first SARS outbreak in 2005. A new version was adopted. And under it, states had this sort of tension where they were willing to give up some sovereignty to the international community and set guidelines for the WHO about how they can respond in emergencies. And so that tension is at the heart of all of these legal obligations, and it sort of reveals how perhaps weak the states have actually made the WHO in this respect. So the primary obligation, the first place we started building these core public health capacities. But then if we have an outbreak or a potential public health event that may be a potential public health emergency of international concern, states have an obligation to notify the WHO and to also provide clinical and epidemiological data to the WHO on that. Now, that sort of foundational obligation is really at the tension of a lot of the critiques about China and the early few weeks of the outbreak. Because in many respects, if what the WHO is not empowered to do is go into a country and actively try and get this information if they feel that a country is not being forthright with this information. They can request and seek verification. And we actually saw that tension playing out with the committees in January when we had groups of experts that the Director General had convened to make an assessment of whether a public health emergency of international concern existed. So that sort of primary notification obligation is there. And then once the Director General, once and if the Director General declares a FEIC, a public health emergency of international concern, which occurred on January 30th, a series of recommendations are issued of how countries should or should not respond to this public health threat. And early on, and as we've seen in past FEICs, this was the 6th FEIC that's been declared under these laws, we saw that there was an express prohibition against international travel and trade bans. And there's some rationale that we can sort of go into if you're interested of why that's so important or has been seen as so important historically. But the reality is those recommendations, which may include the public health measures and best practices above and beyond these international travel ban prohibitions, is that these are not binding. They're not legally binding on states. They are recommendations, and states, when they're revising the IHR, were very express in making sure that there was no sort of binding language around these recommendations. And so historically, and this occurred during the Ebola outbreak in the FEIC in West Africa, the Director General has used public criticism as a way of trying to get countries on board and to comply, because there's no sort of sanction mechanism. There's no way the WHO can sort of try and use a carrot or a stick approach beyond the sort of the court of international public opinion. But what is interesting is back in the original revisions of the IHR, Gro Harlem Brundtland, then Director General, had called out China for not being forthwith with this information back in 2002, 2003. States actually deliberately crafted these IHR, this version, to limit the Director General from doing exactly that. So whilst there was a ceding in sovereignty and allowing the declaration of a FEIC, and putting obligations to notify and share information, it really actually imposed also a number of constraints against WHO and the Director General in particular, and what they can do in trying to hold states to account for these obligations. I think on the agenda in the next year or two, in the next months and year, is going to be significant IHR reform, and panels have already been composed to start that process.
And Jeremy, if I can just pick up for a second, I mean, I think so just putting this in context, right? So we are, sitting here, we're in Washington, D.C., or at least I'm in Washington, D.C. And, down the road is President Trump, who just today, I think, tweeted about the World Health Organization agreeing with him, right? Which is just a deeply ironic thing happening on Twitter. But I think that, just backing up for a second, I think key pieces to understand here, following on what Mara and Alex were saying, is, we've got an international system that's been crafted over many, many decades, but the center of which is national sovereignty. And so you would think, listening to some of the rhetoric, that the World Health Organization was this all-knowing, all-seeing, all-powerful, amazing entity that's supposed to be able to act, right? And I think, if you kind of dig deep into the internet, you can find like all sorts of bizarre theories about the head of the World Health Organization's plane, that he can just fly anywhere and know anything. None of this is true. What we actually have at the World Health Organization is an organization that's smaller than the hospital at George Washington University down the road, probably smaller than the University of Minnesota's hospital system in the Twin Cities, that's trying its best to be able to play all the roles that Mara was describing. And central to that is playing this massive game of getting states and trying to get these powerful countries that have resources and power and politics and the ability to move things that the Director General has no access to, right? To all collaborate. And it is a really challenging thing to try to do. And so when you see, for example, the Trump administration really kind of trying to blame the World Health Organization and moving all of these things, those of us that know the World Health Organization well kind of, roll our eyes a little bit, right? Because good God, of course, the World Health Organization was trying to get information out of China, but China is the second largest economy in the world. It is a major power in the world. It was notable that the other thing that was happening at the time that the outbreak happened is that China and the United States were in a massive trade war, right? So this is not like little politics. This is the global political sphere, the United States and China kind of going at each other. And in the middle of that, the Director General is trying with his little team to steer around and give information in a wide variety of places. And so when you see this kind of role of get information, share that information, figure out how that happens, 100% of that really depends on their ability to cajole and do that. And so as Alex was saying, we've got these grand things that sound really amazing, the international health regulations, right? And, those of us, who spend a lot of time here in the US are very used to regulations are things that if you don't follow them, then the police come. In the international sphere, we have no police. Nobody comes. If people don't follow the IHRs. So this kind of game that's happening is all about politics. It's all about trying to cajole and move things around in really interesting ways. And that's a big part of why we're seeing both compliance and non-compliance. And the final thing I'll just say before I shut up and move on to the next thing is just, one of the things we focused on a lot is, oh, good God, some countries are not following the IHRs. But it is actually remarkable that what's happening around the world is that countries are reporting in real time how many people are getting this disease, knowing that if you are a country with a lot of COVID-19, your travel and trade are going to be restricted and your economy is going to be hit. And yet the World Health Organization has somehow managed to get everybody to keep on largely reporting. Now, there's a few, examples. I don't know what's going on in North Korea, not totally sure what's happening in Tajikistan, but there's a couple of kind of really interesting, examples. But on the whole, it is pretty remarkable what they've been able to do.
Oh, go ahead.
I was saying that makes me think of a quote for the broad international law, sort of beyond global health, that, we also forget that the vast majority of states follow the vast majority of international law most of the time, for me to horribly paraphrase Howard Koh. International law, we often focus on where the rule breaking is as well. But there is, as sort of Matt highlighted from a practical point of view, there is actually a system, even in the absence of a police force or, this court of public opinion. And this is where those norms that Mara was talking about are so important, because it's not just about scientific norms, it's also about political norms and standards of practice that go beyond the text, and as Matt was pointing out.
So let's take some of these ideas at the international level and put them back at the national level and think about, are there characteristics that help us to understand which countries are more likely to comply with these international regulations, or that are more likely to have these robust sorts of public health responses that we talked about earlier? Is it about wealth? Is it about the type of government system? Is it about the type of political leadership? Does it matter what neighborhood you're in sort of a geographic sense? Is some of it luck? Are there things that we can look for and be like, these are the sorts of characteristics that make a country more likely to have a successful response or more likely to cooperate with these international norms around health?
It's really interesting. And I think the answer is no, but yes, right? So here's, political scientist in me, right? Trained in comparative politics thinks, let's apply the frameworks that we know, right? So let's go through some of them, right? As you were saying, wealth. Is it true that richer countries have done better? No. Right? So, and it's really interesting, right? Because one of the things that's out there in the world that we've really been challenged by is there's a lot of measurements of which countries are more prepared to respond to a pandemic. And most of those have been blown out of the water by this pandemic, right? We've seen that most of the states that we thought were best prepared have often failed, right, in their responses, while some who we thought were not prepared are not. And part of that is that often, I think many people mistake wealth for capacity, right? And so one of the things that we've seen is that, if you kind of go down the list, you've seen, Senegal respond remarkably well, right? You've seen, South Korea, certainly a wealthy country, but not the most wealthy. You've seen South Africa respond remarkably well, despite a variety of things, right? You've seen, kind of hugely effective responses from Thailand, which was kind of expected given a variety of things, but also throughout East Asia, right? And so thinking about kind of the role that's happened there. And so I think wealth doesn't hold up for us, right? I mean, you've got the United States, you've got the UK, you've got a variety of other countries that have just responded pretty poorly. So then what else, right? I mean, and I'll just say the other one that's in my world is democracy, right? And so this is really interesting, right? Because there's a lot of work on kind of the relationship between democratic countries responding to health and what happens. And so thinking about your Amartya Sen and your like broad understandings that democracy is good and well. And we're really being challenged by that. Now, I think what we're seeing is that openness and democratic governance has some real benefits, right? And so if we think about the kind of early outbreak in China, we can see ways in which, failures of democracy and openness resulted in the early outbreak moving out in the ways that it did, because people were not responsive, did not respond in the way that they we would hope that they would, and didn't share information, and that the system was not responsive. At the same time, we also have seen non-democratic countries exercise control in powerful ways, right? And so this is really having us kind of ask questions about democracy and kind of what's working and what's not. I think the reality is that some democracies are responding remarkably well, right? And that really vibrant democracies, not just democracies on paper, but democracies that are really able to have a collective sense of responsibility and shared participatory decision making, that many of those countries have actually done really, really well. And then third, I'll just throw out there is, past experience is turning out to be, I think, one of the most important factors here. And, when we think about kind of who was prepared, I think we've underplayed the degree to which kind of past experience has actually shifted the politics of how important and how powerful public health officers and officials and decisions are in countries. And so part of, what you've seen is that many of the countries closest to China, who you would have expected to experience big outbreaks, right? Given just proximity and challenges, including middle-income countries, have actually responded remarkably well because they've learned a lot of lessons from the past. But so too have East and Southern Africa. And there, it's HIV that's been the response, right? That history means not only are there contract tracers who know how to do their jobs, is there a kind of population who's primed and ready to respond to pandemics? Not only is there just some of the best epidemiologic capacity in the world, but there's also a sense that actually this matters. And so ministers of health are powerful, right? They have a big role, right? And that has actually played a huge role because, this idea that we can kind of mobilize this kind of capacity that's out there ready to be used, as in the United States, with the premier international, the premier public health agencies in the world, right? The CDC, the NIH, the HHS, have really failed, while folks with a lot less power and money globally have really succeeded. And a big part of that has been kind of how do you put the political capacity behind the public health capacity.
And I would add to that, without kind of getting too political, there's a certain type of regime or political setup that has really not done well. And that is populist, sort of nationalist regimes. If you look at across the board, sort of the worst performing states, it tends to be countries where the people in power have made a practice of sort of questioning or rejecting expertise, of questioning or rejecting the value of institutions, and questioning or rejecting the value of multilateralism. And therefore, one of the things that was missing, or one of the reasons that all of the indexes, the global health security indexes that help to kind of rank how prepared countries were, maybe missed a little bit, is that they looked at capacity and not necessarily the willingness to use that capacity, or didn't anticipate that you would have governments that have remarkable, public health expertise, CDC and others, or countries that really do have the capacity to scale up their public health systems, to buy PPE, produce PPE, stuff like that, that would actively choose not to do so. And that kind of throws off the metrics, because we didn't expect a non-response.
So before we open things up to our audience in a big way here, I just want to ask about a vaccine, because we hear a lot of until we get some sort of vaccine, it's going to be really hard to lift some of these restrictions, to go back to our previous behaviors. Let's say a vaccine gets developed. What's, if any, sort of international mechanisms exist to help distribute that vaccine or share it? Is it just first come, first serve? Are there vaccine sharing mechanisms? Are there standards that are agreed to, like we're all going to give it to healthcare workers first, and then second priority is going to be this group, and then third is going to be this group? Or is it every country for themselves?
So the short legal answer is that there is no piece of binding international law that has pre-pandemic set the standards and codes of conduct for a novel pathogen and the distribution of a vaccine. We do have a bit of a model in a non-binding piece of international law called the Pandemic Influenza Preparedness Framework. But that gives us nothing about what equitable distribution globally would look like. And so what has sort of developed in this gap, and it's incredibly remarkable, the speed and the scale in which this has developed, is through the WHO and Gavi, the Vaccine Alliance, and CEPI, is one arm of this sort of research and development focus called COVAX. That is a pillar aimed at trying to create a portfolio of candidate vaccines, with the idea that one, or ideally a number of vaccines, will eventually go through the safety and efficacy process and be approved for distribution, and that mechanism can then equitably distribute vaccines globally. There are 92 countries that are eligible to receive vaccine through the COVAX mechanism as countries that are unable to sort of purchase the vaccines themselves. But increasingly, and this has been the real win of the last 2 months or so, as we have wealthy countries now agreeing to participate, not only just providing money to enable the purchase of vaccines for distribution to other countries, but to also use the mechanism to obtain vaccines. And why that's so important is we've seen this, along with this nationalism and populism, we've seen the rise of vaccine nationalism, which was completely predicted. We've written papers about it before the pandemic, and it happened during H1N1 here in the United States, where countries enter into advanced purchase agreements with pharmaceutical manufacturers to get priority access to a vaccine. And in doing so, may shut out not only other countries in getting the vaccine, but also mechanisms, international mechanisms like COVAX. So having these other wealthy countries join COVAX for distribution is good, because it breaks down these norms of trying to get priority access. There are still a few barriers that will be in place in terms of equitable distribution globally, and particular priority access to countries that may not have the capacity, the economic capacity, to implement strict lockdowns or strict measures to control the disease, and are perhaps more reliant on a vaccine. Things like the use of export controls, or still the use of advanced purchase agreements. But that's kind of the distributive justice at the international level, that the COVAX is trying to address that. But then we have that sort of within country distributive justice over, we're going to have a vaccine supply issue. That's likely, at least for the initial period, for sure. And so prioritizing, there've been a number of equitable frameworks of how to prioritize this. COVAX and WHO have developed a model that is very high level and really leaves it up to countries. There's no sort of obligation on countries to fulfill their model. But all of these mechanisms frameworks tend to aim to prioritise healthcare workers and vulnerable populations, in particular, say, elderly populations. And increasingly, and there's this great piece in JAMA today that our colleague Lawrence Gostin is a co-author on, about the importance of ensuring equitable distribution to minority populations who have been hardest hit by COVID-19 because of structural racism and other social determinants of health in accessing healthcare. And these are big questions that countries are going to have to answer. I think the absence of a legal agreement or some sort of legal commitment does help mean that these norms are still a little bit elastic in how this is going to occur, particularly within countries.
And at the risk of just being the Debbie Downer to Alex's, like, things are going somewhat well, I think, all of the things that Alex is describing are maybe working somewhat, but it is just worth keeping in mind at the same time that countries have already done advanced purchase agreements, right? And so what COVAX is actually is able to distribute at this point is actually a small fraction of the total vaccine that will be available at any given time. Why? Because the United States and Europe have already done, and a bunch of other countries have already done, a whole bunch of side deals with all these companies to actually buy up large portions. And we don't actually know right now. Nobody's done the totaling, and they haven't actually shared. We don't actually know what portion have already might be even available to go into something like a shared mechanism. And so that's just really discouraging, right? Because I think there's very much vaccine nationalism, as Alice was saying, is very much happening. And the final thing I'll just say, is that, what has been the international move of power over the last 20 years? It's been the creation of an international trading system, right? The World Trade Organization has been built up, and Alex was kind of mentioning the super challenging environment of WHO not having power to move things, and that there are a few binding treaties within health. And that's where we're kind of trying to build out. The World Trade Organization, on the other hand, has a wide variety of treaties and mechanisms for enforcement. It is remarkable that what do we have going on right now in the world? We have a crisis of trade where the things that are needed by people are being bought up, and we're going to fail to equitably distribute them because there is no coordination between countries and no place where they will come together to agree not to do everything. And the World Trade Organization has nothing to say about it. So while we're thinking a lot about, like, okay, we need to reform the World Health Organization, sure, but how about if we also reform the World Trade Organization? How about if we talk about limiting the power of pharmaceutical companies to, in a global crisis, just sell the majority of stocks of life-saving things to the highest bidder, right? How about if we kind of put those things on the table? And I think in some quarters that is what's happening, alongside the reality that we could produce probably multiple times as much of this vaccine when it's out as we are likely to do, because we're still granting monopolies to the companies. And so that's not, God didn't hand down monopolies and patent systems and these kinds of things, right? And so one of the things that, many folks are talking about, and there's a proposal at the World Trade Organization right now from India and South Africa to actually suspend the trade-related aspects of intellectual property agreement in order to allow countries to produce not just vaccines, but also a variety of treatments, et cetera, under COVID to respond. And I do think that that's really where we need to be going, because in the current system, there's only so far that a kind of voluntary mechanism led by major countries is going to move. There has to be a kind of a power base of the global South. So it's going to be really interesting to see over the coming months, once the vaccine is actually available, what happens and what works in COVID, what doesn't work in COVAX, what doesn't work under COVAX. But I think some real concerns that actually we're still on track to make sure that that wealthy countries have lots and lots of access, and that low-income countries have little bits of access while others go forward.
And just to put like a really fine point on the challenge here, in some cases, it's the same countries that are vocally supporting COVAX, that are talking about the importance of solidarity, that are donating money to COVAX, that have signed onto it, who are also negotiating their own side agreements to purchase the vaccines for their own populations, right? And being driven by this look to your own response, even though they know and they say that, you know, the pandemic ends sooner, everybody is safer if we have some vaccine distributed all over the world rather than the entire population of only a few countries vaccinated. So, you know, there's what countries say and some of what they do and the rest of what they do, and these things are constantly in tension. And this is part of what makes a pandemic response so hard, part of what makes WHO's job so hard, part of what makes reform so hard.
So we're starting to get some questions in the Q&A, so I want to turn our attention to those. And any of the audience members, please do type in any questions that you have to the Q&A, and we'll do our best to get to as many of those as we can. And the first one that comes up has to do looking domestically at the difference between states that have Democratic governors and Republican governors, and if there's a difference in terms of their responses. But I actually want to broaden that out a little bit to wonder about this question of centralization versus decentralization, and how much does that play a role? In the United States, we have a very decentralized public health system. And so what happens in Minnesota is different than what happens in Wisconsin, is different than what happens in DC, whereas other countries have much more of a centralized sort of public health system. So I'm curious, you know, to build off of this question, does centralization matter one way or the other, or, you know, is are there are there successes and failures with all of those different types of systems? So whoever wants to try to take that one on.
So I'll jump in from the sort of legal governance structures and how that impacts, because that ties into then who has authority to act, whether we're talking local, state or federal, and to compare a couple of federations, so federal systems. So if we look at the United States, we look at, say, Germany, and we look at Australia. The strength in federalism is that you have local and state authorities that are able to tailor public health responses to the particular needs of that community, to prioritize resources where they need to be prioritized. And then at the same side, the ability of federalism to use the power of, say, the federal government to negotiate, to get access to goods, to get access to services, and to then distribute as needed over the federation what's required. We've seen in Germany that has been deployed very successfully. In Australia, we've seen a little bit of a breakdown of that federalism. We've seen the borders between states become quite hard, and we've had border closures throughout the country. But then these very sort of localized responses that have tailored the outbreaks and meant that outbreaks and the epidemics have been very much geographically contained within states. We then look at the United States, and what we have is a fracturing where we haven't had that federal overlay. So we've had the local and state responsiveness, and perhaps in many cases not necessarily based on sort of evidence-based approaches, and so the disadvantage of that. And in the absence of a federal leadership, including, you know, CDC guidelines, allocation of resources, you've essentially had things just fall apart. You know, there's that Yeats poem, you know, the widening Gaia. Like, it's kind of that is what has occurred here in the US. This absence of national leadership has allowed these sort of pockets of poor governance to really also dominate and then affect other states in the same way. You know, Mara mentioned before the Global Health Security Index. You know, one of the really telling markers in that index was that public trust of federal authorities was a 0. You know, the United States got a 0, and that wasn't weighted appropriate in the overall score, but that tells you also the dynamics at play in a federal system between state and federal. So that's just one aspect of where federalism could be a very powerful tool, but has actually, the failure to use it has had pretty significant consequences here.
Yeah, and there was someone else in the Q&A who popped up with a question about that issue of public trust and how much trust exists between the governed and the government itself. To shift our focus a little bit geographically, we've had a few questions that have come up about both the responses in Germany and Sweden. Germany has oftentimes been held up as this exemplar, you know, and you've got Angela Merkel, who has a background as a scientist. You're getting kind of, you know, Fauci type responses to some of the leading scientists in German public health. And then you've got Sweden, which has played a bit coy with whether they were trying to go for a herd immunity type strategy in dealing with COVID-19. And if you read the analyses of how Sweden has done, it's really contradictory depending on who you're reading at any point. That it's worked fairly well, that it hasn't worked very well. So I wonder if you can help us to understand those sorts of responses. What seems to have worked really well for Germany, and how do we assess what Sweden is doing? Is there really a good way of figuring out if Sweden's strategy has been successful or not?
So, not being an expert on either Germany or Sweden, I'll take a swing at this and just do so with humility. Most of my work is in East and Southern Africa and the Caribbean. So I think a couple of things. One, on Germany, I don't think it's worth. I think it's worth playing up the point that you made at the beginning, Jeremy, which is just, I think Germany is the poster child for effective public health communication and decisive political orientation, right? What we just know, and we know this from decades of work in public health, is that where there is clear messaging and people are able to take action, and it is explained to them how they can take action to protect themselves and their communities, people do, right? And there's this bizarre thing that's happening in the United States that we can talk about like ad nauseum, right? Of kind of why are there people fighting against masks and all of these things? Most of the world is not actually, dealing with that. And so there's this really interesting thing where Germany was quite hard hit early on in the pandemic. It had a bigger outbreak than the United States did for quite some time, right? Which is I think important to just note. It's not that, countries that have responded well never got COVID, right? There was actually a really significant outbreak in Germany, and, there might still be more, right? I mean, Europe's now struggling with, again, today there's news on France, imposing a number of movement orders again. But what you've seen in Germany really is clear public health messaging and clear political power being put behind public health officials, which has then lessened things. So they've had one approach, even in a federal system, which is pretty interesting, right? And it's not uniform, and there's a variety of things that have gone on within the states within Germany. But that's one piece to just say, and leadership matters a lot more than I think almost everybody, including myself, would have said, right? I'm a political scientist. I'm supposed to have studied these things. I would have underplayed the degree to which kind of very specific leadership has mattered in this pandemic. On Sweden, I think a couple of things are worth saying. One, Sweden is not doing a herd immunity approach. That is not what's happening in Sweden. And it's just worth noting that. Now, it doesn't mean that I agree with what Sweden's doing or that that's the best approach, but it's worth just noticing, right? There is a lot of social distancing happening. There are severe limitations on the size of gatherings. There have been, definite kind of, limitations on what can happen. And there's been huge messaging around how to protect yourself. What's not happening as much is there's not a huge mask mandate and there's not been a lockdown, right? And so, the degree to which a herd immunity approach, which is now currently, for reasons that just escape me entirely, well, they don't escape me entirely. I refuse to believe them, right? Which is now being talked about by the White House, right? It is a literally just deadly approach to an outbreak of disease. And we should just be really clear about that. Sweden is not saying, let's let this disease rip through the population and, old people should probably stay home and stay away, and those that are at higher risk should lock themselves away, and everybody else should just get it because it'll be okay. That is not what's happening in Sweden. And even then, Sweden has twice the death rate that its neighbors do, right? And so it's just worth noting that what Sweden has done is been much more kind of open and, not done a lot of, especially on masks, right? Which has been confusing to me. And what have they seen? They've seen twice the death rate, and they've also seen a much bigger hit on their economy than countries that imposed more restrictions. And so I think part of what we're learning is that there is a way to combine pieces here that that look like a robust response and may look like an overreaction early on, but an overreaction early on is actually what has been required to then result in knocking back the epidemics. And those that have been slow to do so have really struggled to then catch up. And so now Sweden's actually kind of struggling to figure out where does it go from here. It's playing a long game that says it'll be okay, but people in Sweden are not hanging out with each other. They are not holding rallies of thousands of people. They are not doing the approach that's being advocated currently by our government.
Kind of picking up on some of that, and going back to something we were talking about earlier, how are countries monitoring their ongoing success or failure? So Alex, we were talking before we started the panel here about your hometown of Melbourne, which has had to go back to reimposing these sorts of lockdowns. And as all three of you were mentioning earlier, we've seen a lot of debates emerge recently around the question of lockdowns and how effective they are and what sort of pushback that there is. And so I guess I am curious about that ongoing monitoring, but also about the efficacy of these lockdowns. Do we have any sort of sense about whether lockdowns work, or what sorts of characteristics go into these sorts of interruptions to daily life that are more or less effective in terms of trying to break those chains of transmission?
Yeah, there's a lot in there, Jeremy. And I think different countries are using different indicators. I think that the starting point, and we have a piece out in the Lancet tonight responding to the Great Barrington Declaration that Matt mentioned as being used by the White House to try and advocate for a herd immunity approach. And this piece out tonight is 80 scientific public health experts around the world essentially saying that lockdowns have a really important place when healthcare capacity is about to be overwhelmed, when you do not have appropriate testing, tracing, and isolation occurring. And so, a short, sharp, and very appropriately tailored lockdown, which we could define as including business closures, is mass gathering bans. And there are lots of elements to what is a lockdown, a lot of nuance between them. But if we're talking about business closures or limiting to takeaway only, to working from home where possible, and to mass gathering bans are sort of some of the main elements of what a lockdown looks like. And obviously there's a lot of variation. That sort of short way of interrupting transmission to allow healthcare capacity to not be overwhelmed and to implement these public health measures. And so some of those indicators that have been sort of discussed by experts in this piece that we have, for example, is rapid testing within 24 hours. So if you have that capacity and your ability to know that you are tracing at least 80% of contacts. And so here in DC, this is one of the metrics that's being used to work through phases, is looking at how many sort of mystery cases do we have, or how many unknown chains of transmission do we have, as a really informative metric for determining whether you're appropriately conducting contact tracing. And then obviously the isolation for people who are sick, at home if it's mild illness, or in the hospital setting, coupled with quarantining of contacts. And now in a lockdown setting, that quarantining may already be occurring to a large degree, but there's the levels of nuance for household contacts. So, the risk is, if you're not using lockdowns appropriately, if they're being imposed arbitrarily or in a very authoritative manner, if they're being imposed in a way that doesn't provide appropriate support, particularly for already vulnerable populations, then you're going to increase that lack of trust in government. There's going to be this push to reopen on top of other economic interests that are going to be trying to push to reopen. And you lose the opportunity to get your public health system ready to respond. Lockdowns should not be the primary tool. They should be the way of putting the brakes on to get your system in place. I'm really worried about Europe right now. I'm really worried about Germany, I'm worried about France, I'm worried about Spain, that we are going to have a lack of public trust in the use of these measures, and the fact that we haven't had these other public health capacities and these other metrics met, meaning that we have transmission that's occurring beyond the capacity of the public health and hospital systems to cope, particularly in the months ahead.
building off what Alex is saying, another trend that we're seeing is sort of the importance of local data and helping us try to pinpoint interventions, pinpoint partial lockdowns as narrowly as we can, because they're so costly, right? They're socially costly, they're economically costly. You know, a national lockdown is incredibly difficult and probably not politically feasible at this point. And there's advantages and disadvantages to that. The more narrowly you can target the measures, the more pain you're saving, and also, address the problem where it's at and not where it's not at, because resources and everything else are limited, right? But the other side of that is that it turns out that the more localized, the more pinpointed the measures are, in some ways there's more resistance to them, because people don't understand why they have to endure this when their neighbors in the next zip code or in the next state or the next school district or whatever else don't have to, right? When something is a concerted national effort, that's one thing. When something is your kid can't go to school, but down the block their kid can go to school, that's a very different thing, right? And so it speaks to sort of the importance of really good communication and building on pre-existing trust, but also trying to foster trust where it maybe isn't through, very carefully and clearly explaining the data, explaining the rationale for this. But we're seeing pushback in Spain, in New York now, right? Against more targeted measures because they're perceived as being unfair. And that's something that we're going to have to kind of figure out how to juggle moving forward.
One thing I might add just very quickly, one thing that from what Mara was saying is the advances in using genomic epidemiology for viral genome tracing. That's a whole big other discussion, that we could have about the other angles, the legal angles to it. But the ability, when you have a strong public health response, we can actually get down to the point where we are using the viral sequence to determine contact tracing and the levels of generation that we are from contact tracing. So we can have that precision, but we can't when the epidemic is at the scale that we see, say, in the United States.
What about, in some places we've seen efforts to develop an app or some sort of technological sort of solution that would be useful for either contact tracing or as almost an immunity passport. I can verify that I am not sick, or I've taken a test within some reasonable period of time, so I can go about my life. Are there issues with these sorts of technological sorts of responses and using them as ways of trying to, affect the lockdown policies or affect the public policy that countries have imposed around COVID?
So I think there are no silver technological bullets, and I think we are hopefully past the point of that being sought, but I think that there are still groups and countries that are trying to find a technical bullet. Contact tracing apps are different types. That depends on whether it is sharing your data with public health officials. The vast majority of them that we're talking about tend to not be. They tend to be more a proximity notification, where there's information gone back into the system that then tells you if you've been in close contact with someone. And that requires a certain amount of uptake by a population for it to have an effectiveness. Something like immunity passports, though, is a different, completely different kettle of fish. There's a lot we don't know about immunity and SARS-CoV-2. We don't know how long lasting it is. We don't know if the tests that we have, antibody tests, are sufficient to be able to extrapolate whether someone is immune and for what period of time. And whilst it is likely that SARS-CoV-2, from what we know, will give you some degree of, a significant an amount of time. So we're thinking, multiple months and years. So longer than sort of seasonal coronaviruses, but shorter than, other diseases. Is there a process for updating these passports? And I've written about immunity passports before, and I'm happy to share a link to the article with attendees, because it's a very complex matter. The short answer is, the immunity passports risk replicating existing injustices and privileges and disadvantage that exist within society over who can access tests, who can then actually get this sort of privilege to re-enter society. And it also incentivizes individuals to get infected in many respects, because if people don't have any other way to get back to work, to get back to school, and that poses not only health risks to themselves, not just death, but also potential long-term health complications, but the risk of transmitting to other people. And that can be contrasted with, vaccination certificates. Once we have a vaccine, people go get a vaccine. That's a public good, that's a social good, that protects themselves and other people, and does not also come with the health implications of this sort of long COVID, this long-term chronic illness post-COVID infection that we're seeing. So, I think the short answer is technological or silver bullet answers can't replace strong public health systems, and will not be able to replace them whilst we have a pandemic still surging and growing as it is now.
Thank you. Yeah, it's fascinating to think about those questions of kind of the role of technology and the data sharing and how that comes into play with all of these sorts of things. And like you said, because there's so much that we don't yet know about immunity and how how this virus actually acts in the body, it makes it hard to do those sorts of things. I know we've already gone past the time that we had scheduled, and I know that also that all three are out on the East Coast, and so it's even later for the three of you. But before we let you go, I did want to ask each of you one last question, and it's speculative, but what do you think the next 18 months look like? What do you think the likelihood that there's going to be a vaccine? What do you think the political situation is going to look like vis-a-vis COVID? How do you think the WHO is going to fare in the next 18 months? Are countries going to turn to it? Is it going to be weakened by what's going on? You can be as optimistic or as pessimistic as you feel is appropriate, but what do you think the next 18 months might look like? Mara, I'll have you go first.
Thanks so much. So, on some level, I think the next 18 months are going to look more or less, or at least the next year are going to look more or less like the last 9 months have looked. I think we're waiting for a vaccine. I'm hopeful that we will get one. There are questions about how effective it will be. There are issues about the timeline for rollout, the distribution, and so when do I get a vaccine? I don't know the answer to that. In the limbo of that, right, we're going to kind of have to keep doing what we're doing, which is trying to socially distance, everybody wear your mask, working from home where we can, and trying to kind of keep this under control without having to revert to the worst case, like really costly scenarios. I think, on the international level, countries are going to continue this sort of I love you, I hate you dance with multilateralism. They're going to continue trying to develop this framework, and I think there will be support for COVAX, but also the countries that can afford to are going to continue to do what they feel like they need to do to protect their own populations. To end on an optimistic note, I would say that I am cautiously more optimistic about the prospects for meaningful WHO reform and reform of the IHR than I have been at other points in the past. And the reason for that is really just that, we're starting to see countries say some of the stuff that they usually keep quiet out loud. So we're starting to see, Germany and others kind of step up and say, WHO is exactly what we make of it. If we want to reform it, then we're going to have to change what we are doing as states. We can't just mess around with the structure of the Secretariat and expect that this is going to solve the problems. If we want a competent WHO, we have to fund it. And so, words don't always translate into action, but at least they're saying it, and that's a start.
Thank you for that. Matt, what do you think the next 18 months look like?
God, I think there are two possibilities. So look, I think we have learned that the United States plays and even more than we might otherwise have understood, the role of the US in global health and the global politics is massive, and it is not all encompassing. But so much of the dysfunction that we have seen around the world is a direct reflection of dysfunction from the United States government, right? Just to put it just plainly, you know, the massive amount of time that the World Health Organization has had to spend trying to figure out whether or not the Trump administration is going to withdraw from the World Health Organization, as just to be very clear, as a function of a domestic political dispute, right? The Trump administration needing someone to blame, right? The fact that they've had to spend quite so much time on that has undermined all sorts of other work, right? The fact, meanwhile, in a world that is multipolar, but where the United States still plays a really powerful role, the absence of that central coordination reality has meant that there's, you know, that there hasn't been a united front. And actually, I had expected that that would not have nearly the impact that it has had, because we've been more and more multipolar, right? There's so much more power around the world. But it turns out that US hegemony has become a dynamic that the world has counted on in various ways, for better or for worse, right? And that has resulted in, when that is very quickly disappeared, it's been very hard to figure out what you do, because there's nothing to react to. That, to me, says that we might well return to something that is, maybe I'll just be slightly more optimistic, that if the United States decides to re-engage with the world, that we might well be able to move a bunch of things. Don McNeil, who is for those that read the New York Times, who is the New York Times reporter who has been since, I think before I was born, the global infectious disease reporter out there, and who reported for many years on AIDS, and is really quite brilliant. And I've had many interactions with Don, in which pretty much every time what I say to Don is, Don, there's something very important. You have to report on it. And he almost universally says, Matthew, you don't know what you're talking about. Go away. Nothing is good in the world. Like, there is no positive spin. We're not going to, like, AIDS is just going to get worse. Anyway, like that is the relationship I have with Don McNeil. Don is out with a really optimistic piece. And he wrote a thing that was on the New York Times yesterday, I think. And it said basically, like, look, there's a lot of cause for optimism. If you look under the hood, what you're discovering is that people are doing the things that they need to do to stop the pandemic, that many governments are acting the way that they need to, and that there's a kind of very specific set of hurdles that we now know pretty well. And we are on track for a vaccine. And so if we can actually figure out how to put those things together, we could be within 6 to 12 months in a very different position than we are right now. It could actually be a much more optimistic position. And we can see that in countries that are succeeding, right? No one's succeeding universally, but Europe's problem is not untethered from the United States' problem, right? And so how do we think about these things holistically? Let's just put it succinctly. If the election, if Donald Trump is not the president of the United States going forward, it may well be very good for COVID. Whether or not that's the position that anyone wants to take personally, I think there is kind of universal, if you back outside of the United States, there's universal recognition that that is probably would reflect a different kind of engagement in the world, and that is probably a major barrier to getting a hold of this pandemic.
I mean, if Don McNeil is feeling vaguely optimistic, that should give a lot of us some hope. Alex, I'll give you the last word. What do you think the next 18 months look like?
So I'm going to throw in some my non-US hat for a bit of controversy. I think the next 6 months are going to be pretty awful. I think we are going to have the next 3 months in particular across Europe and the United States are going to get very bad. I think that will bleed into the first 3 months of next year to recover from that. I think, though, in the 6 to 12 month period, we will have some promising vaccine candidates that will have some form of approval and start to get rollout in priority populations. And I think that I share that the Don McNeil optimism about a vaccine. I think the bigger question is, what does that mean globally and in terms of equitable distribution globally? Because that is a longer term prospect. And we may move in the 18-month period, we may be then looking into a degree of when we have the immune the immune state shifting, we might then have that this becomes a vaccine that we take with our seasonal flu vaccine each year. I think on the international field, regardless of who wins the presidency, but in particular, even if Vice President Biden wins, I think there's probably going to be an openness from the world, and I say this as an Australian, that maybe the US won't play a dominant role in many of these forums, and will be there'll be opportunity to downplay the US's role. There'll be a bit of hesitation and mistrust that this could all happen again in 4 years' time. And that may not be the worst thing in the world when it comes to getting voices from the global south, when it comes to getting more equitable voices around the world at some of these tables. And so, that may be a cause for optimism in the sort of, 6 to 12 month period as well. It's going to be a tough fall and winter here in the US, but I think there is the light over the 6 to 12 months. Excellent.
Thank you all so much. And I'll just throw in my annual plug. Get your flu shot, people. It's available now. And if nothing else, if our systems are overwhelmed by COVID, they're not going to be able to deal with flu. So get your flu shot, give yourself that extra bit of peace of mind, and hopefully that will help things out. Won't stop COVID, but at least will help hopefully keep some of our healthcare resources available.
And I just want to say thank you to all of you for doing this. It was really interesting to hear two experts talk about this information, including Jeremy. Thank you for hosting and for putting this together and making the context for us. And we've already had a couple of suggestions. I don't know if you saw them, that you should all come back after the election, after a while, and talk about all this again. So I think that it went very well, and I appreciate you sacrificing your time and sharing your expertise with all of us. Thank you so much.